Okay, I've just started recording the session, so just so everyone is aware, this webinar will be recorded and it will be available to those who would like a copy of it, or also to those who weren't able to attend the webinar. So I am recording the session. So I think we'll get started. Let me just move the screen here. Okay. And again, please feel free to ask any questions in the chat facility, and I will facilitate those with our faculty. So I just wanted to welcome everyone to the webinar. We have partners from across the globe, actually. We have all of our partners and customers in Europe. We have partners in the UK joining in Brazil. We have Philippines and Hong Kong in Asia. And then we also have all of our customers, a lot of our customers in South Africa. So thank you for joining us. And I just want to quickly introduce our faculty. We have Professor Shazia Peer. She's head of the ENT department at the Red Cross Children's War Memorial Hospital, where she's been working for 6 years. This is the Children's Hospital associated with UCT, the University of Cape Town. Shazia has completed a fellowship post at the University of Toronto and Sick Kids Hospital in Canada, where she spent 2 years from 2013 to 2015. And she does have an interest in pediatric airway management. So welcome, Shazia. And then we have Professor Darlene Lubbe. She's head of the clinical unit at Groote Hospital, where she's been for 18 years, so with lots of experience. She's also in the division of the ENT department and is affiliated with the University of Cape Town as well. She has an interest in airway management and endoscopic sinus surgery and skull-based surgery. So welcome to Shazia and to Darlene. Okay, so I'm just going to start by talking. The webinar is based on a non-occlusive device, and it's how to manage airways using a non-occlusive device. So the concept of this device was designed for tracheal dilation, and when we were designing this product, we wanted to allow the product to allow continuous oxygenation and ventilation. So the concept was born because of the challenges that were faced when treating tracheal stenosis and using balloon dilatation. So taking and bearing in mind the challenges, we wanted a device to overcome the challenges. So the device needed to provide continuous ventilation. We wanted it to be long enough to be able to use through a rigid bronchoscope and to make the product itself easy to use. And the product had to somehow reduce the risks associated with the previous balloon dilation techniques. And we also wanted the balloon to have a central port for the guide wire to make it easy to use in the dilation. So as you can see, the traditional balloon obstructs the airflow, and then we were able to design a balloon which allowed continuous ventilation, which is indicated in the images. So this balloon that we designed is called the trachelator. It was the first product which dilates airway stenoses while allowing continuous ventilation. And we designed the balloon to allow for over-the-wire catheter and with a cluster of balloons. And the trachelator does allow, it's been proven, for safer airway dilation procedures. And so we were very happy with the final results with the product. It does allow, and it has been proven to allow for ventilation and oxygenation, and it does successfully dilate the airway. It has been shown to enable to avoid a tracheostomy, and most importantly, it allows for a definitive management plan with a team of specialists that's treating the patients. So with the trachelator, we are very pleased to announce, as from yesterday, we have received our FDA approval. So it's very exciting news. We will be expanding into this market as well. And we also have CE approval, so we are able to sell this product worldwide. So that's enough about what I have to say. I'd like to continue moving on with the program, and I'd like to introduce Shazia Peer, and she will continue talking about the pediatric airway stenosis and the management thereof. So Shazia, I'm handing over to you.
Hi, Lisa.
Hello.
Thanks very much for having me. I think it's really wonderful to share a platform with Darlene, my mentor, and someone who I've been very fortunate to work with over the years, and to follow through with implementing, I suppose, the tracholator in a totally different cohort of patients. I'm going to just share my screen and talk at the same time. Let's see if I can achieve that. Give me one moment. I also want to just thank Etienne for being here. Etienne Coetzee is one of our pediatric anaesthetists. Actually, he does do everything, but I'd like to think he has a special interest in pediatric and specifically pediatric airways. So he's with us today as well. Thank you. Can you see that? I'll just put it in full screen mode. How's that? Okay.
Yes, we can see it.
All right, I'm going to go ahead and watch the time as well. So I'm going to talk about this novel use of a non-occlusive balloon dilator for subglottic stenosis. And I want to highlight that this has been a paradigm shift for me, and I'm happy to talk about it because the tracholator, when it was first released, was for the most part a tracheal dilator, and just based on the size in adults, I often wondered how would it ever transgress to the pediatric side. And I must say I have been pleasantly surprised and so pleased with patient response with the non-occlusive balloon dilator. I have subsequently started using it for all of my cases, and I'll tell you why in a few minutes. So I've got no disclosures. I do want to thank DISA for letting me use this platform and for showing some of the work that I've been doing with balloon dilation. I come from this beautiful city. I don't apologize for it being the best place, even without electricity and water sometimes. This is where I work. We're very fortunate that Red Cross Children's Hospital is the first and largest standalone functional hospital for child healthcare in Southern Africa. There are now other centers. It is a state quaternary hospital, and we see a lot of African and national children that are referred to us. And as Lisa mentioned, we're affiliated to the University of Cape Town. We have quite a large cohort of patients that we see, some with complex ENT conditions and certainly airway conditions, and we have quite a busy pediatric intensive care unit. We also have about 20% of our airway referrals to be neonates, and for the most part, some of them are premature. And we do see congenital and acquired subglottic stenosis. This is quite a fair amount of my practice, and this is subsequently why we actually went ahead and started a pediatric airway surgery unit, a group of multidisciplinary specialists, and we have candidacy for laryngotracheoplasties that include obviously endolaryngeal, open, and a combination of both. And so if we looked specifically at subglottic stenosis in children, for those of you who manage this condition, we know that they come from congenital or acquired or mixed. We know about the risk factors, and certainly our biggest risk factor is intubation injury. Meconium aspiration and burns also have extra risk factors, and reflux disease, especially in that really young child who's already been instrumented with an ET tube, definitely has an extra risk factor. And we know that the incidence is higher in intubated neonates. These are children who've had intubation. On the left, burns child. After 5 days, you can see deep cartilage exposure. And then on the right, a child at 2 years of age who was premature and subsequently intubated for 3 months and had a posterior glottic stenosis that persisted, fixed cords because of that, and some cysts below. So we know the spectrum is quite diverse, but still specific to the narrowing, and the need for expansion is quite specific. If there is a membranous expansion or the soft tissue If there's a membranous stenosis or a soft tissue stenosis, we know for sure that a treatment option using an endolaryngeal balloon that dilates has been working in the recent part of our practice. And how that works, as you can see in the schematic diagram on the right, is that there are radial forces that circumferentially dilate the stenosis. It's done through pressure gauge. And what's really beneficial with the balloons were they were deflated when they went in and subsequently inflated through the narrowing. And because of that, we could see beyond it initially. They were narrow and they were flexible. And what was really beneficial for this type of treatment was that we could use it on younger children, the very fragile ones. We also could use it on lower grade of stenosis, shorter stenotic lengths, and specifically for me, a subglottic stenosis. And definitely between the membranous and the fibrous, the more membranous components. Why do we consider it to be advantageous? Is because we know it's less invasive than opening up the airway anteriorly. It's cheaper than having to keep them in ICU or opening the airway. Shorter hospital stays if they have repetitive interventions, less complications. And I do agree with the fact that it does reduce the need for open airway in a significant percentage of patients. And it can be done together with interventional procedures like lasers and cold steel incision. So there's a lot to benefit from it. Historically, our balloons were not airway balloons. We used esophageal balloons, we used cardiac endovascular balloons, and all of them were occlusive because they came from this origin. And we always used a pressure gauge with an insufflator. We dilated with water, so it was hydrostatic pressure. We could see through it, but they were always occluding the airway. So on the right, one can see as it inflates, at the bottom, it completely occludes the airway. So it was only natural that we would have a period of apnea where there was no ventilation. So to summarize that, our traditional methods of dilating the subglottic stenosis involved dilators that totally occluded the airway during dilation. And we accepted this permissive apnea. We pre-oxygenated it if they tolerated it, and hopefully would get through the period of occlusion with subsequent dilation. It had to be completely occluded because we needed to dilate with that strength of the balloon touching the lumen that was stenotic. So if they were poorly tolerated, we'd have to abandon the balloon, deflate it really quickly, and if necessary, rescue ventilate with intubation. And it was a question of whether the dilation would be completely abandoned or we would bring them up to normal saturation levels and try again. So this prompted an interest in me seeing this tracheolator and wondering whether this non-occlusive balloon could provide a really good permissive ventilation in the really small child with smaller lumens and with much less reserve, especially looking at the children with the underlying brittle cardiorespiratory conditions and poor cardiopulmonary reserve. These were children who went in and out of theatre, had long surgical periods and were intubated. And so they were having symptomatic subglottic stenosis that was amenable to endolaryngeal interventions. So they were often seen as poor candidates for balloon dilation. So what if we could do something for them? Because for the most part, those children underwent endolaryngeal surgery, often had significant challenges in maintaining ventilation, and they did really carry high risks for adverse events. For those of you who do endolaryngeal procedures in children and in adults, one must bear in mind that there are a few factors to consider. And this is something that, honestly, with time, I've begun to realize that one must place a lot of attention on these things. One of the most important things we all know is patient selection is key. If somebody's got a glottic and a subglottic stenosis, a very long stenosis, thick cartilaginous component to it, this is not necessarily a candidate for an endolaryngeal procedure. One must have the correct surgical skill set. It is very important to avoid causing more complications to a patient, especially using laser and things like that. One must have the correct microlaryngeal instruments. Some of the instruments are so big that a 2.5 kg child may not even have the anatomy to facilitate a suspension. One must have anesthetic support, so the necessary anesthetist and the anesthetic awareness of having someone be breathing spontaneously and to understand that this is a shared airway is crucial. This is a shared responsibility, and we carry it together. And then, is this going to be a definitive or a temporary treatment? If you take someone to theatre, you got to know, am I going to fix this, or am I going to just get to a point where I can save them now and discuss later? And then post-op plan, we're very fortunate. We have an intensive care unit, we have a high care. Is this somewhere that is possible for you to make these decisions, or do you have to then just cut your losses and do something that is a little bit more foolproof? And then the balloon dilators, struggling through long esophageal balloons, is this the right thing? Can we facilitate something? And have a variety of non-occlusive where possible. So just quickly, the technique that we use, and for those of you who do children, you know that we use a direct laryngoscopy with a telescope, and we have something called a suspension microlaryngoscopy, facilitating us to use both hands with a camera on a telescope in one hand. And these are the instruments that we use. From the left, you can see the Guttenham or the suspension. I always like to have 2 suctions. A 2 millimeter is always ideal with the ball at the end. My forceps is always there, and I've got my Benjamin Lindholm suspension laryngoscopes, and I have 2 sizes with a side port for ventilating, and on the left I put my light carrier source. And then on the right, I always have 4 telescopes. It's a privilege, I must say, to have 2 2.7s and 4 millimeters. And on the right, next to the camera, is the maximum dose, and Etienne will say this, the maximum dose of topicalizing spray with an atomizer that is very good in children to prevent it falling through. We have a Lua lock. So just looking at the technique, which this would be for a non-occlusive and an occlusive balloon, we always have a huddle and we always discuss what we're going to do, maybe 3-4 times. And we always very respectful of the shared airway. So we mask ventilate, we confirm that we can mask ventilate or that it's going to be difficult and predict how quickly we need to move. We have the maximum spray. And then certainly I always advocate that the ENT surgeon has the first look because we have to rescue or intervene. So we would spray the vallecular and have a look at cord mobility, assess that and make sure that that is appropriate. And then we swiftly go into suspension. And on the left, you can see the stack with the monitor and everything on the left. And you can see me in suspension. I also have access to the monitors from the anesthetic side and light carrier. I think this is fantastic because you have one way of using the same source and economizing with that. Again, I am not an anesthetist, and I'm sort of referencing this from the surgeon side, and so Etienne will add what is necessary from his side. I prefer spontaneous ventilation. There's some gas induction with Sevo, and then mask ventilate like we discussed. Always have IV access, and then you want to aim for the most part to have a spontaneous ventilating technique. We use intravenous anesthetic with a combination of those two and dexmedetomidine if we have it as an adjunct. I always pre-oxygenate, and in these cases, when we had an occlusive balloon, this was, gold. We had to make sure that these patients were pre-oxygenated sufficiently. But a lot of the kids have biphasic stridor, they're exhausted, they're sitting with a very narrow stenosis. So you have to work quite quickly, and you hope that what you're providing is enough to go on with the intervention. And so these are ways that we pre-oxygenate. Again, look at the side port, and we have to bear in mind that these kids have a low functional reserve, they're fragile, they may even be a difficult intubation, in which case sometimes we just go through with a telescope and we pop the stenosis. We have a railroaded ET tube on that. So we also know that they may have 2 levels of pathology. So we want to see before we pop, we want to see beyond what we can appreciate with just the laryngoscope. How do we prepare the balloon dilator? Now, I'm going to talk about the non-occlusive because for those of you who are on this, where you've got the occlusive and you've been using it, and I really like this mobile airway card. I love everything that Mike Groote does regarding the airways, and so he's invented this this app, and it's actually quite good. You punch in what you need from the patient side, and it gives you really what you need. So here on the right, you see balloon dilation sizing. It's a 2-year-old, age-appropriate endotracheal tube, outer diameter, 1 size bigger for the larynx, 2 size bigger for the trachea. The non-occlusive fills exactly the same criteria, and so I am going to show you the technique that I use, and this is, for example, a size 7. The outer diameter is there, and we look at the burst pressure, and the tracheolator has the outer diameter written on the outside, short nose in the front, and remember, one can see through it. We prepare it, and so this is how it connects to an insufflator. Like with the other ones, you want to take the air out, and this is just a video of how you prepare it or prime it or make sure that the balloon is actually ready to go when we need it. And so this is a child, a neonate with subglottic stenosis, was intubated at birth for meconium aspiration, was extubated, and then developed stridor a few days after that. And it just progressed. And so you can see it's a thin, soft membranous subglottic stenosis. She was symptomatic, she struggled, but we managed to get her into theatre and we had to work quite quickly. And so this is the video, exact real time at that moment. And you can see we've got some cricoid pressure with the lady's garter. We've got our anesthetist. Everybody's looking on the screen. I haven't edited this, so you can see my fellow Bouchler's got the insufflator. That's me at the helm. I've got suspension in tow, and I'm getting the balloon through the stenosis. You can actually see that. That's my rescue balloon, railroaded over the 2.7. It's real time. I didn't want to edit it, just to show you that we've got that on standby. If we need to, it's in there. And there's the balloon. Behind the anesthetist, you can see the SATs are 99 and 100. And there's the insufflator. I'm ventilating through the side port on the right of the Benjamin Lindholm. Matt, our anesthetist, is connected up on the side, and we're all watching the chest and the monitor. And there we go, we're insufflating. And so our anesthetist locks on the 2 minutes on the clock, her own clock, and she logs it also onto her anesthetic machine. On the left, I haven't edited, you can see my registrar. He's looking at what the burst pressure is, what we need to get to, and we get to that in our first minute, really. And you can see that everything looks good. There's no bucking, the patient is breathing. And then onto the, obviously we do 2 minutes, and now we're deflating. And there was no desaturations at any time. We take the balloon out, and we can see after the first balloon dilation, this is a 2.7 millimeter telescope. And so, so I can go down, and I can see that there's been a disruption of that stenosis, and the child still hasn't required a rescue intubation. I'm going to give it a second balloon dilation, and I'm going to show you that. This is the scope findings, and you can see again, everything is very small. It's a small baby. This is the second balloon dilation. I've been able to look at the telescopic view from above. I can see the stenosis, and this balloon needs to be midway. And as it insufflates, you see all individual balloons stretch out and dilate and compress the outer lumen. The inner lumen of the outer part of the balloon is dilating the inner lumen of the subglottis, and everything is quite small, so the uvula is obviously going to be in the way. But I'm trying to get close enough to show you that there is that central component. I don't use the guide wire, but the child is breathing in between the balloons. So this is now that the balloon has been in there for 2 minutes, and I've got a 4 millimeter telescope, so it's a better view, and I can go all the way down, and this is the dilation. And now I can go further down to see if there's any second pathology or see everything is okay at the bottom and all looks good, and I'm going to come out. So this child did really well. She didn't need to be re-intubated, and I saw her after about 4 weeks and everything is good. So my initial experience in using the non-occlusive balloon was to look at the techniques and outcomes of endolaryngeal airway intervention in children who had specifically brittle cardiorespiratory conditions and cardiopulmonary reserves that were poor, but they did have the symptomatic subglottic stenosis, and they were amenable to balloon dilation. So we looked at 4 kids, and this was about a year ago, and they had undergone the non-occlusive balloon dilation. These were the 4. They were quite young, 7 months, 6 months, 27 months, and 4 months. They varied in weight between 6.9 and 12 and 3.7. All had biphasic stridor. One had mixed, apart from the others had acquired subglottic stenosis, and they also had cysts. And then what we did was we started with a subglottic stenosis Cotton-Meyer grading of 3 or 2. They underwent balloon dilation, 2 2-minute intervals. Nobody needed to have had an abandonment. They tolerated the balloon dilations. All had sustained their SATs of between 95 and 100. They didn't need any rescue intubation, and they improved by 2 values of their Cotton-Meyer grading. And so in summary, I would like to just let everybody know that I feel that the non-occlusive balloon dilator is safe and effective, and it does achieve the required dilation of the laryngotracheal stenosis. And I felt that intraoperatively in these vulnerable children with poor cardiorespiratory reserve, it allowed me to have continuous ventilation while I was dilating. So for me, that just was a game changer. You can ventilate continuously during the balloon dilation. Granted, you don't have a capnograph, but you can see the child is ventilating. There's no bucking against a closed airway. And so to conclude, initially, as I mentioned, the non-occlusive balloon dilator or the tracheolator was found to be effective for vulnerable children. But since then, it's become the standard practice at Red Cross. And I use it for all children with laryngotracheal stenosis that are amenable to endoscopic balloon dilation. And because the results are consistent with the occlusive balloons, I don't see how it can be any, it's just better. It's more effective and it permits ventilation. So it just has that extra sense of security and better technique and improved usage in theatre. So I'm going to hand back to Lisa. We've got some cases if there is time, and I'd like to go through them because they're different pathologies. Thanks, Lisa.
Thank you, Shazia. That was very nice. I appreciated your insights on the procedures and look forward to the cases, I think, afterwards to see more actual procedures. So, Darlene, I will hand over to you if you want to share your screen, and then go for it.
Okay, thank you very much, Lisa. Can you hear me nice and clearly and see my screen?
Yes, I can see your screen and we can hear you.
Okay, great. So I will chat a little bit more about the older child or adults. One of my disclosures that I'm not a pediatric ENT, so I do very few kids. I did contribute to the development of the tracheolator. My name is on the patent with the other members of the DISA team, and hopefully one day I'll have some financial disclosures to share as well. So Lisa showed this slide just on all the tracheolator objectives. But I would like to share the reason why the tracheolator really was developed and for this purpose of ventilation and oxygenation is when I was a young consultant many years ago. Groote Hospital is one of the big trauma hospitals, a very, very big, busy hospital with a big intensive care. So many patients requiring ventilation and then developing post-ventilation tracheal stenosis, often due to inadequate measurement of the cuff pressures during that time. So as a senior consultant, I was asked to attend every one of these procedures where a patient required an emergency airway. And I just thought there had to be a different and an easier way to do this, that it wouldn't always have to be the most senior anaesthetist and most senior ENT. Because what what we found was that if a resident or registrar was asked to manage these patients, the safest way was really to do a tracheostomy and then establish an airway and then deal with the problems later on. But we know that if you do a tracheostomy, you really have messed up the definitive management plan. Often you might have a very small stenosis of a couple of millimeters, and now doing a tracheostomy below the level of the stenosis, you make a 5 millimeter stenosis into a 2 centimeter tracheal problem. So to avoid tracheostomy, to have the ability to just get away with just maybe a tracheal dilation and offer the patient a more definitive plan with a multidisciplinary team being involved. So at our hospital, we have cardiothoracics, ENT, anesthesia, all on a WhatsApp group. And for any airway that comes in, everybody is aware of it. But sometimes even the anaesthetist now manages these airways. And that's my anaesthetist, Ross Hofmeyer. Has been very instrumental in the development of the using the supraglottic airway, or the LMA, for ventilation. So we've really reached a stage where our most junior resident can now easily manage severe stenosis. The anaesthetist can manage this, your pulmonologist, your cardiothoracic surgeons. So I'm going to go through the different techniques because it's slightly different to what Shazia explained. I think the suspension laryngoscopy is still the kind of old-fashioned or the workhorse approach that most ENTs are most familiar with. We don't often use this except if the patient has a tracheostomy already, but there's certainly people that prefer this way, and there's nothing wrong with it. There's different ways that you can ventilate the patient during suspension laryngoscopy. You can do spontaneous breathing. You can have an oxygen cannula in the laryngoscope like Shazia showed. You can occasionally jet ventilate through the center lumen of the balloon itself if you wish to. And what we sometimes do is we dilate, and then we have a couple of minutes of apnea, and then you can put an ET tube through the laryngoscope and just give the patient some oxygen and let the CO2 come down. So we'll go through the different options here. So I'll start with the advantages, the pros for the suspension laryngoscopy. You certainly have a lot of space for your instruments, and you get the most beautiful pictures. You can use your rigid endoscopy through the laryngoscope. And you really have a great view. You can suction in that area and see exactly what's going on. Often manage to even get your endoscope through that balloon to look at the distal segment of the balloon and to make sure that you are in fact beyond the stenosis. So, and ENTs are very familiar with this technique. So I think it is something that's probably mostly used outside of our center. The cons for me is it's definitely it's so easy to ventilate these patients using a supraglottic airway that I still stress a little bit, you know, if we have to do a suspension, because the ventilation is a little bit more difficult, and your anaesthetist has to be kind of confident and familiar with suspension laryngoscopy to give you a good feel to keep the patient still. Obviously, if you put a patient in suspension, you can't have the patient coughing because you can have a neck injury. So it takes a little bit of time to position the patient, and often during that time you have to struggle to ventilate the patient before the balloon is in. Once the balloon is in place, it obviously is easy to ventilate or jet ventilate. One of the cons and something if you have a stenosis is very close to your vocal cords, is that the balloon can be inflated on the edge and be cut on the edge of the laryngoscope. So it's just sometimes I think right in the beginning, a couple of years ago, 4 years ago, we had some what we thought was balloon failures, but in fact it wasn't a balloon failure. It was the fact that the surgeon was inflating the balloon in a rigid either bronchoscope or laryngoscope. So I'll show you this short little video clip. You'll see this patient is in suspension, but he has a trachea, so it's quite easy for us to to manage the patient being ventilated through the tracheostomy. So these are the easier ones, and this is the reason the patient has a trach. He's got a complete stenosis. So you might ask why, how can you use a balloon for the complete stenosis? And I found it very useful. So you'll use a CO2 laser or diode laser to actually core a little lumen, millimeter or a couple of millimeters, and then you can use the balloon in that area to really dilate. And this, even although this patient will require a redilation and might require 2 or 3 dilations, if they need more than that, then we'll usually say, okay, you need a resection. But the advantage is this patient would not have had voice, so you give them the ability to speak. And also you have the ability to now plan whether this patient could just have future dilations, could have a tracheal stent. In order to put a stent in, you need a lumen. So this patient didn't even have a lumen beforehand. What I want to show here, and I'm just pausing it, you see the black center lumen. This is the lumen that can be used for jet insufflation. So if you have even a millimeter stenosis, you can place this center of the balloon at that stenosis and gently jet insufflate. You need to know you're obviously inflating the lungs, so if there's no place for the air to escape, that this can cause barotrauma. And then you have the space between all the balloons that we call the interballoon space. And this is the area where the patient is being ventilated through. We're not supposed to go through there with a camera, but it's just to demonstrate. So the bigger your balloon is, the easier it is to pass a small camera. And you can see obviously a lot of trauma here still, but this is from having no lumen to having a sizable lumen, and I always try and get at least a rigid bronchoscope through there. So even for complete stenosis, there's definitely a place. So we'll go to the next slide. I'll just put the sound down, and this is how we do probably 99% of our cases now, using a supraglottic airway or laryngeal mask airway, and there's certain different ones, and I think Etienne might speak on that. So you can, the advantage here is that you can connect this to the ventilator. So even for very small stenosis, the patient is ventilated 100% in a normal way. And it's amazing, often when there's a junior anaesthetist present in theatre, they don't actually even realize that this would have been a very difficult case, because they're ventilating the patient as per normal. You can also connect a bag and bag the patient normally, jet insufflate through the central lumen of the balloon, and as I said, even for very, very small stenosis, you can use these laryngeal masks. So a very controlled environment, which makes life much easier. So this is an example of using the supraglottic airway. This is Ross Hofmeyer, my anaesthetist, that's passing a guide wire. So we always put the guide wire through the bronchoscope, and I'm actually going to play this video at the same time just to show you. This is probably the most difficult part of the procedure, is to try and find that little hole to put the guide wire through. Once you've done that, the rest is pretty easy. So you can see the flexible scope in the center lumen, and on the right hand side there you can see the guide wire is passed all the way to the carina, and then we feed the balloon over the guide wire. So you do need another hand. Usually I'm sitting in the back, and one of the registrars do most of these procedures. And you can see you can absolutely take your time. The patient is being ventilated. You can see the saturation at the back, 100% even for this small stenosis. So I'll just speed this up. So we feed the balloon over it, and then once the balloon is in place, we use the direct bronchoscopic view, and you can beautifully see the dilation in this area. So occasionally something happens, Ross is not available, or we can't find a suitable laryngeal mask in one of the hospitals. And then this is the old-fashioned way that I manage the tracheal stenosis using rigid bronchoscopy, which is very, very traumatic to the airway. So I might still use a rigid bronchoscope or tracheoscope, but place it just proximal to your stenosis, and then you can use the balloon through the rigid bronchoscope. And this is a major advantage of the traculator above other balloons that are too short and can't fit through a bronchoscope or through a supraglottic airway. And it's very important. In the second picture at the bottom, you'll see you see the little openings on that bronchoscope, and this makes ventilation more difficult. So if you're going to use a bronchoscope, it should be a tracheoscope. The difference is a tracheoscope doesn't have those little openings at the distal end, so it's much easier for the anesthetist to ventilate, and even using the balloon they can ventilate by just connecting the ventilator to the port on the bronchoscope. So pretty easy ventilation as well. So this will be the last video that I'll show you, and this is Ross Hofmeyer and myself just showing you that we can do a awake bronchoscopy, and we have inserted the traculator. Ross is inflating. We inflated up to 6 bar. Obviously, my airway is normal. I didn't have a stenosis, but you can just see the balloon go up in the background. If you look underneath Ross's hand there, and the saturation, you can see 100%. I must say it was a very comfortable procedure. I didn't feel the balloon go through the vocal cords or being inflated in the trachea at all. In fact, I'm actually even maneuvering the bronchoscope myself. The only sensitive area was actually the inferior turbinate and the postnasal space. So it is important to if you're going to do awake, and we have done this, and I think in other centers they've also just published, or it will be published, their awake tracheal dilations. So I think a safe procedure to do in selected patient. I use nebulized lignocaine, so that's what's connected to my nose is oxygen and nebulized lignocaine, which we used 10 minutes before. There you can see I'm showing Ross blow up the balloon even more. He was a little bit hesitant. We're doing this in the kind of little recovery room section of the theatre. And you can see he's continuing to inflate that balloon, and at 6 I said, okay, let's rather stop. Okay, and that's I'll stop there, and I'll hand over to you, Lisa.
Thank you, Darlene. I think that was great insight as to how the adults technique compares to the pediatric technique. And in fact, either technique can be used for pediatric or adults. I think it just depends on the equipment that you have available to you and your area of comfort as well. So thank you for that. That was great insight. And I'd just like to remind everybody, if you do have any questions, please type them in the chat forum, or if you have any suggestions for any topics that you want to be covered, then please you can type that in the chat column as well. So I think, Shazia, will hand over to you if you want to discuss your other cases. I think you had 3 more cases, and then if you want to involve Etienne, if you have any queries or want to maybe hand over to Etienne, and maybe he can address any queries from a ventilation point of view.
I think that's a great idea. One, I just want to say we all don't try that at home. We don't actually balloon dilate each other, even though it may appear that way. And sadly, that we can't do it in children. I've certainly seen it in older children, but we don't have that luxury. So we have to unfortunately take all of them to theatre. And it usually is a case of, is there something congenital that may be adding to what we're anticipating, and there may be other levels. So it is sad and unfortunate, but it is a different, pool of patients. Etienne, I'm going to let you say something while I load the three patients. Is that okay?
Hi, thank you so much. Yeah, so my name is Etienne. I'm one of the anaesthetists. I often work between Groote, Schuur and Red Cross. So my experience with this non-occlusive balloon has been mostly in the pediatric population. I think it's really been a game changer in terms of, like Shazia mentioned, the brittle cardiopulmonary patients that we are often we venture in there with a lot of trepidation in terms of what you can or hope to achieve. So with the patient being able to breathe spontaneously, I know one of the questions were, are we going to aim for spontaneous ventilation or for controlled ventilation? And especially in those patients where you are venturing into the potential unknown, you might want to make a diagnosis and treat the patient. As the anaesthetist, you want to be as compatible and open up as many ventures as possible. One thing that I want to stress that has been a common theme is good communication. I think that's where we are very privileged to have such a good understanding, and before each case, even before the induction, we have a mini huddle because the induction is often a very important part of the whole procedure. And then having, I often rely on a total intravenous anesthetic, as Shazia has mentioned, with a combination between remifentanil, propofol. I usually use dexmedetomidine and sometimes even ketamine. And all of those give us the ability to run a very, very low dose propofol remi concentration and utilize state-of-the-art pharmacokinetic models to maintain anesthesia. And of course, a lot of local anesthesia.
Yeah, I mean, I think even maybe some of these, one of the 2 or 3 of these kids, you may even know, Etienne. I'm going to just show them. Thanks. And feel free to add as you wish, even Darlene, if you wish to add. I'm going to just put it on full screen. This child was actually a burns patient who was intubated for a period of time and was extubated and then developed stridor about a week after extubation. She was a bit more comfortable and not, one of those kids who sit in the ward with biphasic stridor and slowly get tired, and on a Friday afternoon is most tired. So we took her to theatre, put her in suspension, and then proceeded to dilate. And I think what's really beautiful for me is I can see the area that needs to be dilated, and I can pass the scope through there, and I'm able to insufflate and look into the balloon at the same time. And what I really liked about this case was it was very controlled, and we knew obviously we needed to be sure that we could take her to theatre and we could ventilate through there. And what I like about this is even though we can see the misting, you can actually see her ventilating through there. And it's actually very nice to see, because if you had an occlusive balloon, these secretions would just stay below the balloon. And if she did have a permissive apnea of 2 minutes, the moment you took that occlusive balloon out, you would need to suction that and even risk causing a bit of a spasm. So we can clear what's in the lumen of the airway while we dilate. So we allow ventilation, but what's really nice is, even like Etienne would say, okay, I can see it's making a difference, and suction to avoid anything. Do you want to add anything about the capnography and how comfortable you feel, Etienne, with the permissive, allowing us to be in there and knowing that the SATs are what we look at only, really?
So the scope that you are using at the moment, you've got the 2 lumens that you currently have. We appreciate that one lumen, is connected to some oxygen that is passively flowing and just creating an increased inspired oxygen concentration for the patient. What I often like to do is to hook up our capnograph. If you are finished with the, often the light source is useful for introducing your rigid scope. Once that is completed, you can then hook up your capnograph to the other port. And then have not really quantitative measurement of CO2, but at least a qualitative measure of, are you still moving gas? And that's a very helpful technique, as opposed to trying to palpate on the patient's abdomen, to control the ventilation and see if you are over or underdosing your opiate.
And do you generally find that you are getting, a representative reading, and that we are actually ventilating through this time?
Yes, yes, absolutely. And it gives me a lot of confidence to allow you to properly dilate. And often, like you've mentioned, perhaps a repeat dilatation without us having to taking the time to, get the oxygen saturation back up. And the other concern that we often run into is, if you should occlude the trachea, you now have a patient that's progressively trying to buck against this occluded airway. Are you perhaps introducing some pulmonary trauma, negative pressure edema, which is rare in children, but it's still something that I'm worried about. And with this, it negates all of those concerns. Yeah,
you're absolutely right. It sort of takes away all of that, and if anything, it mimics the as close as it can to normal ventilation. So these are the other two cases. This is a 16-month-old with complete congenital tracheal rings, and she came through to us from a different hospital, having been intubated for 4 weeks. And this was quite, had damaged the stenosis quite significantly, but we did a slide and we slid into right main bronchus. And because she had a ventilator-induced myopathy, she had pooling of secretions, and she failed extubation and failed extubation. And, just with suction trauma, there was a lot of injury to the repair, and she just struggled to extubate. So 5 weeks post-repair, that's what it looked like. And this was 6 weeks post-slide, and we just couldn't get the tube out. So she had a soft tissue stenosis at that proximal site, and very vulnerable, very weak and fragile. And so we needed to get the tube out. And so we used the non-occlusive balloon dilator, and we serially dilated. And it's a nice video because you can see the balloon is going all the way down to trachea. It's a small enough child that I can put her into suspension. It's a little bit fast forwarded. I'm left-handed, so you can see my left hand puts the balloon in. I dilate. The anaesthetist presses the button for 2 minutes. You can see in the back the sats remain 100. And this is real time. I've just fast forwarded it. And again, you can see the insufflator on the right. We get to burst pressure. And we basically wait the 2 minutes out, and she never desaturates, and we never need to abandon. And this was really good, and we actually got her extubated, and we managed to get out of ICU and get her home. And this is what it looked like. So this for me was also amazing. I mean, tracheal, you always worry about how far down you can go in suspension. And then there's the one last case, and then Etienne, if you want to add anything to this, or you want me to, what did you feel? I mean, you've probably been there when we dilated Letone. We did her quite a few times.
Yeah, I think the fact that you can reach such a distal part, while, I mean, the more distal you go, the likelier the chances that you're going to run into occlusive issues, or, having disastrous, like airway reflexes. And having the non-occlusive balloon, like I've mentioned before, it gives you a lot more confidence to complete and fully dilate and try to do the treatment to completion for the as a standard of you're setting up for treatment and not just for an attempt.
Yeah, that for me was really good, because in the first time I did it, I used fluoroscopic guidance to see where it was, and then when I dilated, I could see through the lumen, so I didn't have to do it every time, which was great because you avoid all that radiation. And then this is the last case. What I like about this is like you said, diagnostic but also interventional. This was a 5-month-old girl with DeGeorge. She had a single ventricle. She was post-shunt. Baseline oxygen saturation of 88%, and there she was with her fancy congenital subglottic stenosis. How on earth am I going to get this tube out? But she had to fix the anorectal malformation. So now I'm sitting with this child with anorectal surgery, no leak. She's failed extubation a few times, and I can't do a trachea because my cardiac surgeon is not going to be happy with that. So what do you do? So I said, well, let's try this non-occlusive balloon and see what happens. But I can actually do a little bit more. I can do an anterior cricoid split and then balloon dilate. So is it going to be good enough to dilate cartilage? Am I going to get that same balloon dilation that I'm expecting? And so I was pleasantly surprised that I could do my anterior cricoid split. And then I put in this balloon and I could ventilate her through there. And she was so brittle that we didn't actually struggle with her SATs going below 88. Sure, it stayed at 88, but it was actually a non-event. And we managed to do a second balloon dilation. And you can see actually between the balloons as well. And you can see it stretched out the cartilage quite nicely, which is amazing. This is just the second balloon. It's exactly at the same time twice for 2 minutes, just to get that cartilage stretched out. You know, you want to get a good stretch and expand successfully. And then, you know, which is typical for our surgery, is we would re-intubate with half a size bigger for a few days. And she was great. She remained asymptomatic after we extubated her. She's now a year later. It's really good. She's avoided any other surgery, actually. So I was very impressed with that. I think you've been with us, Etienne, with the anterior cricoid splits and those things. Those are very vulnerable kids too. So we have to get a wider lumen, and they pretty much tolerate these things quite well.
Yes, I think if you want to give an anesthetist a tachycardia, you must introduce a univentricular heart patient that you want to treat for tracheal stenosis. And as you've mentioned, that ability to continuously ventilate is definitely a game changer.
Yeah. Well, thanks so much for your input. I'm going to stop sharing and hand over back to you, Lisa. Thanks, Etienne.
Thank you, Shazia. Thank you, Etienne. That was just phenomenal to see, and it's so nice to see the succession that you've had with these cases and the vulnerable children. And thank you, Etienne. I did appreciate your insights from the anesthetic point of view and how you manage these patients. I think it's very important, and just to prove that it does provide a safe way to treat these patients. So it's been very exciting for us to be involved with the design and development of a medical device to be able to provide the doctors with a safer airway dilation solution when treating these stenoses. So it's been very exciting for us. So I just want to open the floor. I don't see any questions. I'm not sure if anybody has any questions that they want to ask before we finish off, unless Darlene, would you like to close off, or do you have anything further that you'd like to add?
No, thank you very much. That's a great presentation, Shazia. It's amazing that you can actually manage that little airway with a balloon, I must say. Well, what size, what is the smallest size, Lisa, that you do have?
6. The smallest size is a 6 millimeter.
Yeah.
And I can confirm there are 9 different balloon sizes available. I have in the question box here. So the sizes are 6, 7, 8, 9, 10, and then 12, 14, 16, and 18. So we do have a whole range of balloon sizes available to accommodate neonates, pediatrics, and adults.
Shazia, maybe I can just ask you, if you do a redilation, so bring a patient back at a second sitting, not the same sitting, do you often go up a size in the balloon or not?
So we choose the size based on what would be the size of the endotracheal tube for that patient. And so if I have a congenitally narrow child, then I would stick with that age and size that's appropriate. If, for example, we've done an anterior cricoid split or we've widened the airway, then certainly I would go up half a size. So it would depend on what was narrow. If it was just membranous and that was a correct size of the airway, I wouldn't go up one, because you want, as you have invented this balloon, there is a level of complete, if you go up to the burst pressure, it's not compliant, and that's what you want. You want something that gives you sustained pressure. So if you get too big a balloon, then you can't actually get to burst pressure. So you don't get that shearing force that we actually want. It's a semi-compliant balloon. Now, I may be wrong, but that's how I see it. So I want to get the appropriate size. So sometimes I take the patient back the second time and I would use the same balloon if I know that the size of the cartilage is right, but the sort of lumen is the problem, the membranous part is the problem. Yeah. So it depends.
That's something that we haven't discussed. The slipping of a balloon, any balloon, is that something that you see in kids as well, or not really? It's mostly membranous.
I used to see it a lot with the esophageal balloons, that we call it the watermelon seed effect. And I was always very worried that the esophageal one had that little tail in the front that would trickle down into the bronchi. This one doesn't slip down. So even if it does hold on, you've got too big a balloon. If you've got too small a balloon, you can just see more air coming through the middle, but it doesn't slip. I don't see it.
Something that I found is if you do have slippage of that balloon, it's actually an indication that it's a very solid cartilaginous stenosis, and that's often an indication that you might need more than just a balloon dilatation. It doesn't actually matter what pressure or what kind of balloon or how you dilate it, but there's a good chance that that patient might need a resection or laser or a cricoid split. So I think that's always a question we get, will this balloon not slip like other balloons? But I think if any balloon slips, you have to think, okay, we might need to consider something else in this patient.
And certainly for the children, when there is a cartilaginous component, we call it laryngeal framework. If your framework is actually the problem, no matter how much you dilate, you're not going to win. We can usually see it even without slippage. You can just see that this needs to be cut open and expanded. And you're right, ours doesn't slip, but certainly you can see that it's just not going to work. And how many times do you dilate? I dilate only twice before I decide something that needs more. Obviously, in different facilities, some people don't have an open airway surgery facility. They don't do reconstruction, and this is all that's available. So I can't, prescribe it. But what do you do?
Yeah, so I think that's a difficult question, but I also feel if you have too dilatation and it fails, or there's a early restenosis, so especially in your burns patients, you're going to need a stent for that patient. Even if you dilate 100 times, it's not going to work. So I would normally start thinking after 2 that something else needs to be done. But having said that, there are certain patients who might be 80 years old who needs to come every 18 months for a dilation. And I would rather have that than have the risk of a tracheal resection in a very elderly or a patient that can't sustain major surgery. So I think there are exceptions, and one has to also look at what the disease process is. Is it an autoimmune disease process like IgG4 sclerosing disease that you might dilate? Then you get the diagnosis. They go on immunosuppressants, and then your next dilation is going to be successful. Where if you did 10, it wouldn't be successful, but you do 1, they go on immunosuppressants, and the next one will be successful. So I think one has to, you kind of have an idea that maybe after 2, there's something else going on that you should consider.
You're right. And also, like in our case with the children, D. George's, you try twice, I wouldn't do more. They must have cartilage open, because they have an inflammatory reaction that's submucosal. So you're going to get more fibrous tissue. You're going to get hardened stenosis. So I agree. You have to make a decision for the more complicated underlying pathologies. Yeah. I must say, I think it has, for me, made me more confident to stay longer. How do you feel about staying longer than 2 minutes?
I do.
I know that we have enough information in the literature for this. So, you know, I do see a full, sort of like almost like a healthy 2 minutes, you know, it's like a little here and a little bit there. And sometimes you feel a give. You know, the person who's giving you that pressure gauge and you actually putting in the balloon, you sometimes feel a give. And that's something I don't know that I felt with the non-occlusive, with the occlusive one. Do you feel that, Darlene?
So what I do is I do 3 minutes, and then but often you do it, and then you're not 100% sure. You look and the dilation isn't perfect, and then I think often it wasn't in the right place. So, or if someone else is holding the balloon and you have a perception that there's been a bit of slippage, then what I do is I will take over. I'll put the balloon in place, but rather than try and go up to 8 bar, 10 bar, you know, within seconds, I would maybe go up to 2 bar and actually leave it there for half a minute, and then I slowly turn it up, and I find that way, you know, it gives a little bit of a give, as you say, and then your second dilation at 3 minutes, for 3 minutes at maximum, is actually the one that counts. What we've also started doing, I mean, there isn't evidence, there's a lot of literature around, but they use triamcinolone in other countries. We don't have it available in South Africa, so we use a laryngeal needle, and then we inject into the lumen, or often now inject on the outside, just a little bit of steroids, and then with the second dilation, you have the steroids being theoretically kind of dissipating around the tissues, you know. Yeah. But I mean, we haven't looked at our outcomes and things like that. One thing that I can say with the balloons, I mean, we've had so many patients years ago walking around with tracheostomies, or you know, with a very high morbidity because of tracheal stenosis. And we have very few. I think I know of 3 patients who have permanent tracheostomies, and most of them can be. And so the balloon gives you those that you can't sort out. It gives you the opportunity to be able to sort them out and give them a good quality of life by saying, okay, you know, you've got in 2 weeks' time, you're going for a resection, or you're doing that. So you don't have that emergency airway drama that you have with a patient waking up with a tracheostomy.
Yeah, and I think that for me, if I wasn't an open airway surgeon, if I was somewhere where I had resources, but I wasn't trained in open airway, this would be something you can use to make a diagnosis that, hang on, I've made a grade 3 to a grade 1, I now need to send them somewhere. But at least I've managed this child without a trachea safely, and maybe done some cutting and realized this is a bit more fibrotic than I need, but you've spared them a trachea at a younger age, you've spared them actually of obstructing and getting hypoxic, and then you refer to a center like ours for an open airway. So you've given them like a year of their life where they otherwise would have had, you know, a trachea or something, a tracheostomy. So this kind of balloon gives people a little bit more confidence that they can go to theater and not have a crash and burn. You know, people get really by that. And small children, I must say, anterior larynx, very difficult things. You know, you struggle already. You struggle with communication with the in-laws and, you know, the anesthetist and stuff. So if you can get something that communicates well on both sides, it's actually really good. The one thing I did want to say, and I can add to Darlene's cohort, is if you've got a 12-year-old, they tend to be quite long and tall. So we also use an LMA, but you have to have a very skilled person who does bronchoscopies. Pediatric pulmonologists are excellent, and I have someone in my other non-university center where we put in a 3-way. Darlene, you put in a
we use a bronchial blocker, yes.
Bronchial blocker, and we have managed to put in a laser. So we had a patient with a tracheal web. Unfortunately, I don't have the videos here now because I couldn't get consent from the family to show you, but a tracheal web from intubation, and this child continued with it, and she was 12 now. So all my telescopes were just too short. I couldn't reach it. I think, Darlene, you were actually there with us when we tried it. So we ended up the second time subsequently bringing her to theatre, put in an LMA, put in that bronchial connection, and put in a laser through one side. So we made the cut just on one edge and then balloon dilated. And it was such a great result that you actually can do more than just balloon dilate. You can balloon dilate, see, and do it all dynamically and ventilate through the whole thing.
In the first couple of cases, we actually used a diode laser. I can't remember the size. The size would depend on your size of your balloon, but you can put the diode laser through the center lumen of the trachea. So that's for the complete stenosis or the small stenosis. So you can actually use the center lumen to guide your diode laser. We've changed that technique to rather use the balloon if we use a laser, diode laser, we actually use it through the bronchoscope. But the risk is that you might damage the bronchoscope if your fiber is broken. So it's almost safer to use it through the balloon, but it's a little bit more difficult to maneuver your laser in the right spot. Maybe I can just quickly mention from the pediatric side, because I do very little pediatrics except for the choanal atresia cases now and again, is even although I do a posterior septectomy and really do kind of big surgery to open their posterior choana, you still find these patients, because you operate on them when they're 2-3 days old, restenose. So what I've started using is you can use any balloon, but the tracheal later was available. And I must say, I've only done it in one case, but I've been absolutely amazed at the 3-month outcome using the balloon for choanal atresia. So I think that's for revision choanal atresia. Unless it's a small membranous stenosis. So that's something that I think is we can investigate and possibly also indication for use.
Yeah, certainly.
Okay, thank you both. I just have one question, I think, to finish off. And perhaps, Darlene, this might be more for you because it's COVID related, but do you have any outcomes or patients that you've treated for COVID, or not for COVID, from the intubation from COVID? And do you have any experience or have any outcomes that you can comment on treating patients that had COVID?
It's unfortunately a massive problem. So we completely inundated with those patients, even although here in South Africa, in the unit where we are, only 33% of your patients that are intubated end up or leaving the ICU. But most of them have problems, and our incidence of tracheal stenosis has increased dramatically, because these patients are ventilated for 3-4 months sometimes, and they're very sick, so they're hypertensive, and they are really difficult to manage from an airway perspective, because they're all quite obese. They've got no necks or very thick necks, so you can't easily do a tracheal resection, or it's impossible. And what I found with the COVID patients, their stenosis are often multiple levels. So it'll be at the glottis, and lower trachea. And that's then almost impossible to stent. So we're sitting with a post-COVID population that is not resection candidates. A lot of them are not stent candidates. And they're very difficult balloon candidates as well, because the LMA might not work on them, so you actually have to do rigid bronchoscopy. So we've had some good outcomes. There's one patient, perhaps 2 patients, COVID patients, that we can't even balloon dilate because we can't get a rigid a laryngoscope in because of the neck. So that's something that one almost has to consider awake, or if they have tracheostomy, to while they're awake be able to try and pass the balloon to dilate them. So I think the balloon is going to be useful. I'm not sure it's going to be able to treat all of these patients, because the ones that I've seen, some of them are very hard cartilaginous stenosis, so it's a lot of damage. And the second one is tracheomalacia, so the cartilage is gone essentially. So I think what we're going to have to do is preventative, meaning that when these patients have been ventilated for a long time, at the time of extubation, or very early, within 24 hours, is to evaluate that airway and to intervene with possibly dilation, within 24-48 hours to prevent these problems. Because once it's happened, it's too late. So I think as a standard, all of these patients should actually have bronchoscopy at the time of extubation.
Okay, that's a very interesting concept, and I'd be interested to know if anybody, and even in the private hospitals, are doing that, but I think it's a great consideration. But thanks for the comments there. I don't see any more questions. Shazia, did you want to say anything? I don't suppose you've seen any patients or any children with COVID or ex-COVID.
We see them, with the atypically immune compromised from something else, and we've done a few tracheostomies. We have had some subglottic stenosis, but like Darlene is saying, we get in there early because there's so few of them, and we dilate them. But if they're going to get a tracheostomy, we still dilate them because there's obviously a risk that long-term it'll be quite fibrotic by the time they get to us, but not to the degree that we're seeing them in adults. We've had obviously the sirs and the misses, this systemic responses, but not to the numbers that the adults do. I want to say that this, yes, it is the balloon provides the same results, at least from my personal experience, as the occlusive ones, but there's no harm in continuing to have permissive ventilation, and that's something that I think everybody wants. They want to have a lighter burden when they take someone to theatre. So bear that in mind, it can only actually be better with these balloons. At least I found that. Moving forward.
Okay, I'd like to thank you both very much for sharing your experiences, your techniques. It's just so valuable to hear how this balloon has changed the way you practice and how it's improved the way you practice. So thank you very much for your time. I know time is very precious. So I thank you wholeheartedly for your time and for enabling this webinar to take place. And I hope that everybody that's attended it has found some value and has answered questions. And please feel free to email myself or your contact person if you have any further questions. So I think I will close out now, and just to say thank you to the faculty, to Shazia, to Darlene. Thank you, Etienne, for your insight with regards to the anesthesia.
You're most welcome.
Thank you. Thanks so much.
Thank you all. Okay, I'm going to end the meeting. Bye.
Well done, Lisa.